Welcome to Clinicians Corner. Here, Molly and I will provide you with evidence-based insights and practical tools for addressing ultra-processed food addiction. This segment is designed for both individuals navigating recovery and professionals supporting clients through the treatment process. We will be bridging personal experience with clinical expertise to enhance understanding about the treatment of food addiction and the many pathways to recovery.
Each episode explores key topics such as the neurobiology of addiction, strategies for sustainable recovery, behavioral interventions, and the impact of diet trauma. We'll also discuss practical approaches for fostering self-compassion, managing setbacks, and building individualized, empowering eating practices.
Whether you are in recovery or a clinician working with clients, Clinicians Corner offers research-informed perspectives, real-world applications, and therapeutic tools to support long-term healing.
Join us the first Friday of each month for thoughtful conversations that equip you with the knowledge and strategies needed for meaningful progress in ultra-processed food addiction recovery.
Expert insights,
practical tools,
transforming recovery one conversation at a time. Hello, Molly.
Hi. How are you?
I'm good. How are you doing today?
Good. I'm excited to talk about what we're going to talk about.
Yeah, I thought this is something we talk about in Sweet Sobriety a lot because we have a community that is long-term. And so we see this come up very frequently. And I think as we both used to work in the substance use disorder field, we would see it all the time with clients, but it's a topic that is not well known in the ultra processed food addiction world. And so I think this may help either clinicians or even clients who might be dealing with this to understand it a little bit more. So you're probably wondering, what is this thing she's talking about?
What are you talking about?
Yeah. So we refer to it as PAWS, and that is post-acute withdrawal syndrome. And this really describes kind of the lingering emotional, psychological, physical withdrawal symptoms that persist beyond the initial acute detox phase. So, we're all pretty familiar with maybe day 2 through like 5 or 7 of how we feel when we've stopped using a substance, which is, maybe irritable, maybe I'm getting headaches, maybe I can't sleep, all of those withdrawal symptoms. What we're going to talk about today is prolonged post-acute withdrawal symptoms. And this is really symptoms that persist or resurface at 3 months, 6 months, 24 months post-abstinence. And this has a lot to do with neuroplasticity. It also has a lot to do with long-term dopamine recovery. It has a lot to do with psychological adaptations and individual variability, right? So I think it's what we often find in Sweet Sobriety is people will report, well, I've been doing this for 3 months, or maybe they're at the 6 months mark and they're like, I don't get it. All of a sudden, some of my symptoms are coming back. I'm having more cravings. Like, what am I doing wrong? What is not working? And this is a time where I actually get excited because I'm like, it's your brain rewiring. And yeah, it's going to be hard. Yeah, it's going to be painful, but it's actually a really positive sign of recovery. So have you as well? I mean, obviously we talk about it all the time. So I know you experience with clients, but what are some ways you frame this for them?
Yeah, first I like to name it that post-acute withdrawal syndrome. And I first learned about it, like you said, when I was working in, other substance use disorder treatment type areas. And it has always surprised me, and I say always, but like in the last 5-6 years working in this specific field, it's surprised me that we aren't talking about it. And when we are talking about a substance use disorder, which ultra processed food use disorder is, it is a substance use disorder, we really have to be aware that when we remove substances, that there are impacts, like you were saying, on the brain. And I would add even cognitive symptoms show up as part of it, not just emotional and physiological, but also cognitive. And so the way that I like to frame it is name it, both a post-acute withdrawal syndrome. I like to say on average, it does show up for people around that 3 to 6 month mark, like you said. And I like to frame it as like thinking about it as like, we know what the acute phase of withdrawal looks like. It's very physical. We often have headache and nausea, We can have cramps, trouble sleeping. It can really feel like we've been hit by the flu, right? So like when we think about being sick or whatever. And then after those first 3 to 5 days, up to 14, whatever that time frame is for people, then we move into like that post-acute phase and that initial post-acute phase, like you were saying. So I always say to my folks, hey, listen, give yourself 30 to 45 days for your brain to stabilize because you're going to go through it. No matter what you believe about food addiction and withdrawal, listen to the people you're working with because they are going through it. And so then, like you said, like I might give them a heads up about what to be looking for down the line, especially if they're in that pink cloud phase. Have you experienced pink cloud phase with your clients where they're just like, yes, this is amazing.
This is the answer to everything in my life.
I feel so good.
Yes, exactly.
I can't imagine it being bad. I don't understand when people are struggling. What is that about? They can't identify with that. But what then? So especially when people, and I tell them this, I'm like, I don't want to burst that pink cloud. I don't want to pop your bubble, your balloon. I don't want to be that person who rains on your parade. However, I do want to make you aware of post-acute withdrawal syndrome that actually nobody escapes. In no substance use disorder do we ever escape this. It might not show up as early as it does for other people. It might show up down the line. In fact, I had a client who did not experience it until about 22 months in, which is like, definitely there's always exceptions to the rule. Right. And so I just like to name it and then I like to educate on it. And I like to talk about the symptoms. And you started to talk about the symptoms. I don't know if you want to get into like more specifics instead of like such broad categories. Yeah.
Yeah, I think it would be helpful to talk about kind of some things I've noticed at that even the research talks about at neurobiological levels is there's this downregulation of dopamine, right? And what happens is this often leads to anhedonia, which is kind of that, feeling of like nothing is really, we have that pink cloud, but then we also have that nothing's really giving me joy.
Meh, right? The meh.
Yeah. That
or
is
depressed.
exactly.
Yeah. Just that low energy, low mood.
Right. And that
apathetic
pairs with a lack of motivation, right?
Yes.
Dopamine is all about motivation.
Yes.
And so I think that's really important. And I think what also I notice is that, the brain may be still responding to that stress response bias. And so like, even though the substance has been removed, we tend to have this like a bit of lag that people can experience. And so that's pretty much like neurologically what I would say that I've noticed in clients and probably just like clinically in general. So psychological symptoms, I would say, is maybe mood flattening or anxiety, depressive symptoms start to return. This is always when we start to get those food dreams. And that food dreams are also a sign of the brain rewiring. So it makes sense that we're going to start to have more of those. And that's when clients are like, oh no, is this a craving? Does this mean this is going to happen again? Not necessarily. It's really could just be that this is that brain rewiring happening. I may start to notice maybe some more intrusive thoughts, maybe even some more cravings tied to emotional cues. I think those are some of the ones, or maybe some sensitivity to emotional triggers that we notice going on. What about you that you've noticed symptom wise?
Yeah. So all of those things for sure. So I like to frame it as like, think about what I'll say to clients is like, okay, remember acute withdrawal, how it was very physical, those things, like you said. Post-acute withdrawal has a little bit of physical and a lot of what you were just saying, the psychological, emotional aspect of things, where the acute phase is mostly physical, but it's going to have some of those other aspects. It just gets flipped. And so, yes, my clients experience exactly what you were saying, things like the brain fog, that emotional dysregulation of like irritability and that low mood that can just, like you said, then it's like that motivation collapse can happen where it's like, whoa, like it's like hitting a wall, or like you're driving a car and it just dies.
Yeah, like I don't want to do my food plan anymore. My food is boring. Like that's all what I hear too.
Right. My food plan's boring. I don't want to do it anymore. What's the point? I've been good for so long. What if I tried one of these things? What if I actually can have those things? And like you said, the heightened sensitivity of just like, we're just like prickly is kind of the way that I think about it, is like, we're like walking around and it's just like everything can feel like a zing, like, oh, that comment from the coworker, zing, even though they meant nothing by it, right? Or that weird email sign off, or, somebody in group looked funny or had a funny look on their face when I was sharing a thing, when really it has nothing to do with that. It's like you were saying, our brain rewiring, those sleep disturbances can really come back, which just doubles down then on some of these things, the mood, the sensitivity, the dysregulation. It can increase cravings because now we're feeling driven to find more energy dense food because we're not getting enough sleep. So those, like you said, those resurfacing food thoughts and dreams, the fatigue, the exhaustion, again, driving us to find want to have more food, even sometimes like existential dread, like you were like in the depression, anxiety that can really show back up. Like we can really start to get into those freeze states or those really like numb states too. And I'm glad that we're talking about this, because I want to normalize that. Something that's been coming up in group, because we've been talking about motivational collapse a little bit, motivation collapse, is that, something that's been shared recently is, somebody said, I really believed that when I put these substances down, that my problems would go away. And I understand that. I understand that because you have so many voices out there telling you that if you would just quit drinking, if you would just quit eating the junk food, if you would just put down the cigarettes, these problems would go away. And here's the truth of the matter. Problems existed before you started using those substances. Those substances became the solution. In using those substances, more problems were created. So when we put down those substances, some of those problems do resolve. Absolutely. Some of those problems just become more manageable. And some of those problems that were being medicated, quote, medicated by those substances now are going to flare. So it's like this cyclical thing of like, oh, now, again, if it's going to be bad, why even put down? Why not just pick back up? If it's going to be bad anyway, right?
Yeah. And I guess that's where we have to learn new coping skills.
Yes.
So that is where we start to, because this is also a stage where I would hear from clients, oh, I've been using these coping skills and they're not working anymore. And it's like, this is where we need them to like, okay, now you got to try new ones. Some of our coping skills are not going to last forever. And we have to be flexible in saying, okay, this maybe used to work, but now this I'm progressed in a different stage of recovery. And maybe I need to try some other tools and see how they work, because we're always constantly learning and growing. But that's often a comment I hear from clients.
I would agree. And that's where I would say too, it doesn't necessarily mean those things have stopped working. They just don't work for the phase, like you were saying, that you're in right now. So it's like, think about like if you were sick with an illness and, you get out of the hospital and like, now you're in this pink cloud place, right? Like, okay, I've put it down, or whatever, right? I'm feeling great. But then like the illness starts to creep back up again, or symptoms, not necessarily even the illness, just symptoms are starting to show up as you are withdrawing from the thing that was keeping them at bay. So now it's almost like, oh, I have to like kind of like go back into ICU a little bit, right? I need to maybe shrink my world a little bit because now I know I'm vulnerable, those sensitivities. I am more vulnerable to the billboard sign that I drive by every day down the interstate on my way to work.
Where it used to not bother me at all. So why is it bothering me now? And that can be really frustrating for clients because they were like, I thought I had this figured out.
Right. And not only frustrating, but dysregulating to the brain and nervous system that is currently working on recalibrating. And so it's like this, what is happening right now? Like you said, like, I was able to ignore it. I could just I knew what mile marker it was at. I'm just going to I'm going to look at the horses on the other side of the road as I go by or whatever it might be, right? Like you've come up with something and now you're just you're picking it up out of the corner of your eye. And pretty soon you're like, damn, that does sound good. Oh, wait a minute. What happened there?
Yes. And how am I, we often go to that place, like, how am I failing? right?
Right.
Or how am I doing this wrong? And it's like, no, this is just actually the trajectory of recovery. And it's not talked about enough in our.
No.
And so that's, I think, why it's so important we're having this conversation today. And I think we can also touch on like, what are maybe some risk factors for people for prolonged pause? I would say early onset for sure. So the younger you were exposed, will lead to greater dopamine adaptation. And that we know, and it's also with other substances, all other substances in the substance use disorder spectrum, the amount of time you use, so duration of use. If you were one of those long-term daily users on hyperpalatable foods, that means that your habitual and your neurochemical kind of, patterns or pathways are pretty deeply ingrained. And so this may mean that over time, they're going to take longer to heal. If you also maybe have a history of trauma or adverse childhood experiences, it was a coping strategy for that. And so I think this really just lets us know that it may really heighten these withdrawal symptoms, which, that nervous system dysregulation, which can be worsened by PTSD, definitely may also create like more amplified post-acute withdrawal syndromes.
Yes.
And I think the other thing that definitely the research pointed to was that, women, but women are going to experience it in a more intense ways, because even studies with, I think it was female rodents, showed that they had longer lasting dopamine deficiency and more intense withdrawal behaviors. And so this really could mean, and we also have more hormones that are going to impact intensity and sensitivity during post-acute withdrawal.
Yeah, absolutely. There are all kinds. I think that's a really great reminder for all of us, right? Is that we cannot compare our insides to somebody else's outsides, because we don't know what every single, obstacle anybody is trying to overcome. So not only are there hormones, but there's chronic illness. I mean, how many of the clients that we work with have some form of chronic illness, whether it be chronic fatigue, fibromyalgia, colitis, like autoimmune disorders, that kind of thing. Those things are all going to also contribute to, like you said, the severity and the length of time that we're going to experience it. Something that I really think is important to stress is that this is why we remind people over and over and over again, healing is not a linear journey, that we can be doing all things correctly. We can be weighing and measuring our food if that's what feels right for us. We can be eating 3 meals a day if that's what feels right for us. We can be moving our body, drinking our water, getting our sleep, and snapback can still happen. And here's the thing. Here's the piece that I really want to put out there, is that oftentimes post-acute withdrawal syndrome symptoms are misinterpreted by people who don't know and understand as relapse warning signs.
Yes.
And here's the thing. These are not relapse warning signs. These are a part of the healing arc. And while they do make you more vulnerable to recurrence, 1 is not a guarantee. 2 does not make you a bad person, because again, remember what I said, nobody gets past this stage. I don't know when it's coming for you, but nobody gets past this stage.
But be mindful of it.
Yes, yes. And this is why the earlier we can educate on it and the more informed our clients are about it, they can come at it with, like you were saying, like skills, tools, asking for support. This is a time, because of that sensitivity and that risk for return to use. This is where, or recurrence, this is where a lot of times people will reach out to me to work with me individually, or, hey, can I come to Sweet Sobriety to the group? I'm like, absolutely. Maybe you feel like you've got your sea legs for the first 3 to 6 months or whatever, but then all of a sudden you're feeling smacked up alongside the head. Please, you are always welcome to come and get what you need within our community. For sure.
Yeah, because I think you're right. Like, you do kind of need that long-term support planning, right? That is what I would say would be just a common treatment condition of this, is to expect and plan for symptoms to return around like 3, 6, 12 months beyond. and know you're not failing. You're just deepening your recovery. And what that means is you do need to continue therapy or support groups. You may need to go back to what it looked like in the early days, which feels like, oh no, why am I going backwards? But it's just like, when my acute vulnerability returns, I'm going to treat it the way it deserves to be treated. And then I get to go right back to where I began. It's just more support we're looking for during that. And so like when I think about other things we can be doing, I would say making sure that you have meaningful non-food rewards, right? Rebuilding that dopamine responsiveness, whether it's connection, creativity, nature, movement. It might be something to think about supplement wise too, whether that's omega-3s, maybe it's tyrosine, maybe this is a time where I used to use L-glutamine and I haven't used it in a while. Now this is going to be a time maybe where I'm going to bring it back and just use it a little bit. It doesn't mean again, like anything's wrong. It's just like, I'm just treating what's happening in that moment for me. And then stress management is also going to be really key and critical during this. I don't want to, put myself in a place where I have extra additional stressors at this point. This isn't the point in my recovery when I want to try all new things. This is the time when I want to slow down, turn inward, get more support, just really add in that self-care.
Yeah, I agree with all of that. And so, it's like you were saying, that increased connection and support. Maybe it's in groups, maybe it's free peer support groups, maybe it's 12-step rooms, maybe it is, maybe there's a church group that you love and are connected to. For us, I think, and I don't want to speak for you, but I know for a lot of the clients that I see individually, but also within our community, something that they've really talked about is having that community of people who are in the same storm as them, that they are all working towards something very similar. But seriously, find that connection and that support wherever makes sense to you. Like you were saying, the structure going back, you're right. I think clients are like, why do I have to, I'm failing, something's wrong. Why do I have to go backwards? This isn't working for me. And I don't want to minimize what you're going through. I do just want to say though, this is so common and normal when you are on, this kind of journey to get out of substance use and get into your life, and that it's like getting a vaccine boost, or whatever. Maybe you're not, maybe people are anti-vaccine. I don't know, but that's the best way for me to think about it, right? Is that we get these vaccinations as babies and then over time they wear off. And so then we need to get these boosters, right? Maybe it's the Tdap, maybe it's the flu, whatever it might be. And so that doesn't mean you failed or that your immune system is failing. What it just means is I just need a boost. I just need that touch point to get my sea legs again so I can move forward in a way that is safe and regulating and supportive so that I can be successful for the long term. Not that I'm going to be successful quickly. I think that's the other thing is we have to address those expectations of linear progress and how fast it's going to go, because those expectations, especially in post-acute withdrawal syndrome phases, is a killer. It's a huge killer, and I don't know about you, but again, in our community, I see people doing this all the time and I see it because I do it myself, right? It's we are so quick to dismiss, like you were saying, those wins, those things that we're getting. We're so quick to dismiss them. We're always moving that goalpost of get there quicker. I've spent 5 decades of my life in the food. I'm ready to be out of it. And so we think we have to get there. And I've really been asking our people, our community to what would it be like to just tread water right here? What would it be like to just pause, just tread water, do enough to move you toward your goal, just those tiny little things. And at least bottom line, right, bare minimum, don't do anything to make it worse. Can we just sit in the discomfort? Can we just pause right here and do these tiny little things? And maybe it is going back to those basics, around our meals, around our movement, around our sleep, but just those tiny things. What was working before? Can I just, that's the thing I'm doing. Yeah. And like you were saying too, sometimes in that space, that grounding, that journaling, that getting outside and revisiting that big why. What is my preferred future? What am I actually working toward, right? Reminding ourselves of like, oh yeah, because I want to be able to get down on the floor with my children or grandchildren and get back up. Or I want to be able to get on that plane and fly across the country and know that I'm going to be able to walk off that plane when I get there and I'm going to be okay, right? Like whatever that preferred future is, maybe it's time to revisit it. So those would be like the things that I say to clients or how I would work with clients around it, especially for anybody who's listening who feels like that's the hat that you wear. But what about for the clinicians? Like how would you talk to the clinicians who might be listening who are working with clients if you wanted to educate them on post-acute withdrawal?
Yeah, I think I would specifically say that it's critical that they understand it themselves. So if they don't, go in the substance use disorder literature and educate themselves as to what is happening for clients and normalize it with clients that, know the client's trajectory when they're showing up and, oh, this is 3 months and this is what they're reporting. It's really, really critical that you can be supportive of that person with the correct information so that that individual can feel validated in what's occurring for them. And, I've seen for some people, some of my clients, depending on some of those, situations I explained that can make this post-acute withdrawal syndrome worse, I've seen it last in a client for up to a month. And you need to be able to intensively support your client through that.
Without you, the clinician, getting frustrated or losing hope or pushing any of your expectations
on them. It needs to be like, oh yeah, this is so hard. I'm so sorry that you're going through this. Like how can we make things just simpler for you? How can we just allow you to just be in this space of survival, right? Until we get to the other side. That's when sometimes we need to go back to one day at a time and just unconditionally, lovingly support them through this very challenging time, because now they're really going through it, and this will be a time where they have this really high risk for return to use, like you said. And so, but getting them through this will also set them up for more success in when it shows up again. Then they'll be like, oh, I know this. I've been through this and I can do this. And that's just helping that empowered client feel like, yeah, this is possible. Oh, okay. And maybe then they can show up like me and I'm saying, oh, this is so great. Your brain's rewiring. Awesome. This is healing. And they're like,
right. The client is never appreciative.
Yeah, no, they do not. They do not like that. I get so excited for them.
Same. They're looking at me like I am like the devil incarnate, just standing there. They're like, how could you be so excited about my misery? And I just want to reassure you, I'm not excited about your misery at all. I'm just excited that you've hit this new phase of healing. It's like when people are going through something and they're really angry and they're like, why are you so excited about anger? I'm like, because anger is such a expressive and empowering, and it has movement to it, right? Where you're going to do something. And the same is true for this, where it's going to be uncomfortable, but it is really exciting because those neurons are rewiring that parallel competing neural pathway that you're laying down. It's like your brain is saying, are you sure? Are you sure that's what you want? Are you sure you don't want to do the old thing? And you're like, nope, I want to do the new thing. This is really important that the things that we wire together, fire together. So we want to make sure that we're going back to basics if we need to, all of those things. So would you say anything else to the professionals maybe listening?
I would also say this may be a time when a client may have a reoccurrence, a return to use. And this is exactly why you need to have so much compassion for this and hold so much more space for this, because again, it's not bringing them back to day one. We're now in a different phase of their recovery. And so we need to help them, compassionately and with curiosity, explore, okay, this is what might be going on right now. How can we do things a little bit differently? Because this also will be a really vulnerable time for, clients. And I think if we don't acknowledge that as a clinician, and with the client themselves, then they will go to that shame and blame. And, this can be a thing that can make people leave recovery. And that is the last thing that we want to have happen.
Totally. Yeah. And to further stress that is why it's so important that if you're a professional and you're listening and you don't know anything about post-acute withdrawal syndrome, please do go get educated, because you do need to educate your clients as soon as possible. Because when we can do that education, that's one of the first things. And I know that like people are not going to retain that information, but I need to start planting those seeds, because like you said, if I'm waiting for them to be in post-acute withdrawal and then they're full of shame because, oh my God, I'm failing or whatever it is that's happening, they're not going to come see me. I've lost that opportunity to now support them through that because they think that they've failed, or that yet again, another program didn't work, or whatever it might be. So the sooner I can talk about it and the more often I can talk about it, just that reminder of like, hey, we just want to be on the lookout for it. We don't want to be fearful, because now we're like, that whole fear of like relapse. I'm like, again, it's not about relapse. It's about rewiring. It's about healing. So the sooner we can talk about it, the longer we can talk about it. It's really interesting to like watch people kind of like not sail through it with flying colors as if they're like not experiencing distress or dysregulation or, anything painful, but that they don't have that like extra layer of like inner critic chatter, whatever. It's more just like damn it, this is part of the healing. This sucks. It's like, like when your leg is broken and you're healing, and then it's like, it goes through that painful, like last phase as the bones are, mending together. And you're like, oh, I wish I could massage it or something, and you can't quite get to it. I also think that it's important that clinicians frame it accurately, right? That it's a developmental phase of this journey, that the person has done nothing wrong, and that it is not like panic mode. Oh my gosh, we're going to relapse. I think that clinicians should really have a lot of skills around tools like motivational interviewing or solution-focused brief therapy, those kind of modalities that really support autonomy and self-compassion and self-determination. I think that clinicians need to be open to the idea of supporting harm reduction techniques if they're needed, right? So if abstinence is faltering, are we checking in what needs aren't being met? Is there a way that we can get them to tread water and not make it worse?
Or by going completely off, because yeah, exactly. So what would it look like? What do you need during this phase to help you get through to the other side?
Exactly. And can we do that? Can we hold that there without saying, oh, this is a return to use, or this is, oh, now we're back at day 0, or whatever it is that this gets framed. And the thing is the reason why we talk about this, folks, is because these are people come to us and have had these very real experiences. So we're trying to name them. We're trying to give you alternative frameworks through which to see it. And finally, to your point about like all these layers of things, if you're a clinician listening to this and you work with clients who are in substance use disorder treatment, you need to know how to assess for co-occurring issues. You don't have to know how to treat them. Please, you need to operate within like your scope of practice for ethical and legal reasons. I am a stickler for that. If you are not licensed or trained or any of the things to treat some of these things, get out of the way, help that person find the people who can help them with that. So these are going to be things like trauma, grief, depression, chronic illness. Do we need to be sending folks in for psych evals, for medication checks, because a lot of times these medications need to be changed after they've been on food for a while, and not just the biological, aspect of things with blood pressure and diabetes, but also antidepressants, anti-anxieties, antipsychotics. There are all kinds of things happening, and you need to know how to spot those things and say, listen, this is beyond me. This isn't a matter of the client not working hard enough. This isn't a matter of them not doing it right. This might be a matter of we need to have a bigger team to come in and help us, because those issues and concerns and disorders amplify the post-acute withdrawal syndrome symptoms.
Oh, that is so powerful, because I've certainly had lots of clients on different medications that have been creating adverse, symptoms. When maybe now that they've been eating this way for 3 to 6 months, they could have released weight. They are, the way that they're metabolically adjusting to this medication, they may need to come down on medication. So I think that all of that is critical, and that's not my job. That's for me to say to the client, have you checked in with your psychiatrist? lately? Have you checked in with your physician lately about the changes that you're doing and how long you've been doing and what you've noticed, and you're telling your symptoms? Would it be helpful for me and you in a session to maybe go through and like write them all down? And then that way you would have something to take to your professional so that they could get a very accurate view of what's going on for you right now. Because sometimes when we show up to those appointments, we aren't always able to remember all of the things that have changed. But if you're working with somebody regular, I've certainly noticed, and we can certainly discuss that together. And so, I think having those discussions with our clients can be really helpful as well. And to know that there is definitely certain clients I can work with in my scope of practice where I can do some trauma work as a social worker. But if I am just a coach, I'm going to maybe say it could be really beneficial for you to explore some trauma work. Would you like me to help you find somebody in your area that might work with that? And maybe we're going through psychology today together with the client, and I'm asking them like, what would let you know that would be the right person to work with? What about this, profile? Would you be open to meeting with a few of these people for, 15 whatever minutes? I'm not worried at this point that I'm losing a client or, it's not about me. It's like, how can I help this person in front of me get all of the help they need? Because this is such a complex disorder.
Right. Absolutely. So what I'm hearing you say is take your ego and get out of the way. And sorry to be so blunt, but that's what it is. And I guess, also to say that stop telling the client that if they just put down the substances, these problems will all go away and they must still be using or whatever it might be, because none of that is true. And so, I guess like to kind of wrap it up, some of my final thoughts on this topic, because this is one that I'm actually I'm passionate about all of the things, but post-acute withdrawal syndrome, especially the protracted, prolonged aspect of things, has been kind of like something that I'm really passionate about. And I just want to remind
you're going to do maybe a little webinar on
I'll
it.
do a little webinar that we'll give for
really
free.
Helpful. Yeah.
I'm happy to give that for free because that's how much I believe in the fact that when people have this information, they can armor themselves up in the way that they need to and be able to move forward. So we'll absolutely have that on our website for folks to be able to go check out. But here's the thing, okay? Post-acute withdrawal syndrome is not a failure, right? It's like you said, it's recalibration, it's healing, it's new neurons forming and wiring new pathways. Recovery asks for patience. Right? There's very little room for perfection here. It asks for patience. So when you are in that space, can you tread water? Can you tolerate a month of having to negotiate with your body, with your brain, with your emotions in a different way while it's rewiring, because you're not broken. You are just healing is really what's happening. And for the clinicians out there listening, my final thought would be, please, please, please hold compassionate curiosity for what is happening with your clients and put more weight on that over your clinical urgency, right? If we are so afraid that our clients are headed for relapse, we will absolutely drive them to relapse. Okay. And that's not even a word that we use, but I know that's a word that other people use. So I'm going to use that word for them. But that's the thing, is that I'm actually not afraid of return to use, whether my client is using heroin, IV injecting, or methamphetamine or potato chips. I am not urgent over this belief that they're going to return to use. What I am going to do is hold compassionate curiosity to be able to ask those questions so that they themselves can figure out what's going on with support so that we can figure out what is actually needed so people can move forward. So I don't know, any final thoughts from you, Clarissa?
No, I feel like I'm just like so emotionally filled by this conversation today. And all your final thoughts are just, they land up exactly the way that they are meant to be presented. And I hope that people listening, if they do have more questions about that, they can reach out to us. And we have a Food Junkies email, right?
We sure do.
I'm I'm so bad. We have so many shows and I never know the emails to them all.
Yeah, right. And I never remember. No, I'm just kidding. I do remember what they are. So our email, if you have more questions about this, you want to know more, whatever it might be, the email is just foodjunkiespodcast, all one word, @gmail.com.
Awesome. Well, I will see you next month, Molly.
Yay. Well, hopefully I see you before then.
We see each other every day.
Thank you.
Bye. Thanks for joining us this week on Food Junkies Recovery from Food Addiction. Make sure to join our Facebook group, Sugar Free for Life Support Group. I'm Sweet Enough. Molly and Clarissa are food addiction professionals who offer one-to-one counseling and group coaching through Sweet Sobriety. Please subscribe to our show so you never miss an episode. While you're at it, if you found value in today's episode, we'd appreciate you leaving us a review on your favorite platform. Your feedback helps grow our show and allows us to reach others who need to hear this message of recovery. Don't forget to pick up a copy of Dr. Tarman's book, Food Junkies. And as Vera always says, the power is ours.